Right now, I mean, millions of people are celebrating these shrinking numbers on their scales. You see it everywhere,
Oh, yeah, absolutely everywhere.
whether it's through the, incredible advances in bariatric surgery or just this massive cultural wave of GLP-1 medications like Ozempic. Rapid weight loss is just, well, it's all over our feeds.
Right, we see the new wardrobes, the viral before and after photos, the celebration of reverse diabetes, all of that.
Exactly. But underneath those clothes, away from the Instagram filters, there is this hidden structural collapse happening.
And it is happening in the most intimate parts of the human body. We are talking about really profound anatomical shifts here.
Shifts that are basically entirely absent from the public conversation.
Completely absent, which, it leaves so many people feeling isolated. They assume there's something uniquely wrong with their own bodies when in reality they are experiencing a documented physiological consequence of extreme weight loss.
So, welcome to the deep dive. Today, we're taking a highly specific, kind of fascinating journey into this medical blind spot.
It really is a blind spot.
It is. We are going to explore how chronic weight loss physically alters the connective tissue and the fat pads of the female anatomy, specifically the labia majora and the mons pubis.
And we're not just skimming the surface here. We are going from the macroscopic changes you can see in a mirror all the way down to the microscopic architecture of our skin and fat cells.
Because to understand the physical discomfort and, the visible changes people are experiencing, we have to look at the cellular scaffolding. Extreme weight loss doesn't just melt fat.
Right. It fundamentally alters the physical material your body is actually made of.
So let's start with how this area is naturally built. Before we look at the collapse, we really need to understand the original architecture. From an anatomical standpoint, what exactly are we looking at when we talk about the labia majora?
Well, developmentally, the labia majora, which are the outer lips of the female genitalia, are actually derived from the exact same embryonic tissues that give rise to the scrotum in males.
Oh, wow, okay.
Yeah. And functionally, they consist of two prominent folds of adipose tissue, which is really just the clinical term for fat.
But this fat isn't just sitting there loosely, right?
No, not at all. It is secured by a highly complex network of loose connective tissue. And the entire structure is covered by epithelium or, skin.
I found their core anatomical functions so interesting in the reading because they aren't just aesthetic.
Right. They are heavily engineered by evolution to act as the body's natural protection.
Yeah, they cushion and cover the incredibly delicate structures nested inside them. So the labia minora, the clitoris, the urethra, the vaginal opening, you can really think of the labia majora as the shock absorbers,
That's a great way to put it.
like the protective bumpers of the female anatomy. It's a functional cushion that relies almost entirely on fat to do its job.
The fat pad there is totally structural. It provides a vital physical barrier against friction and impact during walking, running, or intercourse.
Because without that specific volume of fat, what happens?
Well, the underlying tissues are just completely exposed to the elements and to mechanical friction.
Which sets up the core tension of this entire deep dive for you listening. If these vital structures rely so heavily on fat to function as a cushion, what happens when a person introduces a medication or gets a stomach bypass where the primary goal is to burn fat everywhere at an accelerated rate?
The body doesn't get to choose where it keeps its shock absorbers. Systemic weight loss is systemic.
So to see how that plays out, we have to drop down to the cellular level, right?
Exactly. We have to look at a concept popularized back in the 1990s by a physician named Dr. Ted Lockwood. He identified something called the superficial fascial system.
Or the SFS.
Mm.
I want to spend some time here because the SFS is really the key to everything we were talking about today. How should we visualize this system?
Picture a three-dimensional web of connective tissue fibers. This fibrous web links the deeper layers of your skin, the dermis, all the way down to the underlying muscle layer.
So it acts like an internal support net.
Right. Now, suspended within the compartments of this net are your adipocytes, your fat cells.
Okay, so if we use a honeycomb analogy, the wax walls of the honeycomb would be the SFS, the connective tissue,
Yeah, perfect.
and the honey stuffed inside those little hexagonal compartments would be the fat cells.
That works perfectly. In medical terms, those wax walls of the honeycomb are called septa. They are just bands of connective tissue that divide and support the fat.
Got it. So let's look at what happens during the obesity phase.
Well, when a patient gains a significant amount of weight, the adipocytes, the honey in our analogy, have to massively expand to store all that excess energy.
Because the body's just doing what it's designed to do, right? Storing fuel for a famine that never comes.
Exactly. And as those fat cells inflate, they physically push outward against the septa. those walls of the SFS.
which causes a generalized mechanical stretching of those connective tissue fibers in the overlying skin.
Right, it's a state of constant, immense physical tension.
It's like a balloon that has been inflated to its absolute maximum capacity and just left that way for 10 years.
Yeah, the rubber of the balloon is under constant stress.
But then, the environment changes. The patient takes a GLP-1 medication like Ozempic, or they have bariatric surgery. The weight starts plummeting.
And this is where the mechanics get really interesting.
Right, let's talk about how that fat leaves the honeycomb. Because the fat cells themselves don't just vanish, do they?
No, they don't. The cells generally don't disappear. There can be a small amount of programmed cell death, called apoptosis during extreme weight loss, but the primary mechanism is a process called lipolysis.
Let's define lipolysis for anyone who hasn't taken biology in a while.
Sure, lipolysis is essentially the chemical process where the body breaks down the stored lipids, or fats, inside the cell to use them for energy.
And medications like GLP-1 receptor agonists are incredibly effective at this.
Very effective. They increase lipolysis while simultaneously inhibiting the body's ability to store new lipids. So the adipocytes rapidly empty their contents.
They shrink drastically.
Yeah, sometimes they shrink so much they become practically atrophic.
So the honey is completely drained out of the honeycomb. But here is the massive structural problem. The wax walls, those connective tissue septa, they don't just magically snap back to their original shape, do they?
They do not. Returning to your balloon analogy, when you finally let the air out of a balloon that's been overinflated for years, the rubber doesn't shrink back to a tight, smooth, perfect little circle.
Right, it's totally permanently stretched out.
It's stretched, it's wrinkled, and the structural integrity of the rubber is just compromised.
And the research in our sources proves this isn't just a metaphor. You can actually see this permanent damage under a microscope.
You really can. Some of the studies used a specialized imaging technique called the picrocereus polarized light method to look at the skin and tissue of patients after massive weight loss.
And what did they find?
Those histological findings are striking. We are looking at changes to the physical shape and structure of the fibers, what we call the morphometrics of the tissue.
Okay, so what does normal tissue look like?
In normal, healthy tissue, you see a high density of thick, highly organized collagen fibers. That is what gives skin and connective tissue its strength and tautness.
But after rapid weight loss.
There is a sudden and significant reduction in those thick collagen fibers. They're largely just gone.
Wow.
Yeah. Instead, the tissue is flooded with thin, misaligned, and loosely arranged collagen fibers.
It's like the material itself is downgraded.
Exactly. And on top of that, the elastic fibers, the elastin that allows skin to bounce back, are often damaged, disorganized, or completely absent in these patients.
So it's a total breakdown of the scaffolding. The material has literally changed from a strong, organized cable to a frayed, weak thread.
Right. And the literature has a very specific name for this condition. They call it SFS failure.
SFS failure.
It is the perfect storm. You have a massive volume loss because the fat cells are empty, combined with an irreversible stretching and thinning of the connective tissue septa that are supposed to hold everything up.
The web simply fails. It can no longer support the overlying tissue, which leads to extreme laxity.
Exactly.
Okay, so we've established the cellular reality. We know why the SFS fails. Let's bring this back to the macroscopic level, the reality of looking in the mirror and, getting dressed every day.
Right, the day-to-day impact.
Yeah. How does SFS failure specifically manifest in the labia majora fat pads?
Well, it manifests as a profound deflation effect. Because the connective tissue septa have lost all their elasticity and the fat is gone, the labia majora entirely lose their volume.
So they just collapse.
They do. The outer lips appear deflated, flattened, heavily wrinkled, or significantly saggy. And in the medical aesthetic world, this phenomenon is increasingly being referred to as Ozempic vulva.
Which is a very buzzy term, but it describes a stark anatomical reality.
It really does.
And what really stood out in the sources is that this deflation doesn't happen in a vacuum. It triggers a domino effect across the rest of the intimate anatomy.
Particularly involving the labia minora, the inner lips.
Right. Think back to the primary function of the labia majora. They are the protective outer cushion.
And when that cushion deflates and flattens out, the labia minora are suddenly exposed. To the patient, it often looks like their inner lips have suddenly grown or elongated.
But they haven't actually changed size at all, have they?
No, they haven't. The tide just went out, leaving the rocks totally exposed.
That is such a good visual.
The minora are exactly the same size they always were. Their surrounding protective tissue has just vanished.
And this regional collapse extends upward as well, right?
Yes, to the mons pubis. That's the prominent fat pad sitting directly over the pubic bone. It suffers from the exact same SFS failure.
Because the skin and tissue there are stretched out from the previous weight. So when the fat leaves the mons pubis, gravity just takes over.
Exactly. The excess, unsupported skin begins to sag downward. It often creates a visible, heavy pouch of loose tissue that hangs over the genital area.
It fundamentally changes the entire anatomical contour and silhouette of the pelvic region.
It does.
Which brings us to the most important question for anyone actually experiencing this. Is this primarily a cosmetic issue? I mean, are patients just feeling self-conscious in the locker room, or does this collapse of the SFS actually cause physical, mechanical problems?
The aesthetic changes certainly impact self-confidence, body image, and intimate relationships. That's undeniable.
Right.
But the functional discomfort is very real, and it is frequently the driving force that pushes patients to seek medical intervention.
Because the shock absorbers we talked about earlier are gone.
Yes. Just imagine trying to run, cycle, or even just walk briskly when your natural physical barrier against friction has been removed.
I can't even imagine.
You are left with redundant, loose skin rubbing against itself and exposed inner anatomy rubbing against clothing.
I imagine even wearing normal underwear or jeans becomes agonizing.
It really does. Patients report severe chafing, chronic skin irritation, and recurrent infections in the folds of the loose skin.
Ugh, that sounds awful.
And furthermore, that fat layer previously provided deep cushioning for underlying nerves and highly sensitive tissues. Without it, the simple act of sitting for long periods or, riding a bike can cause friction-related nerve pain and tremendous discomfort.
It is such a brutal irony. You do all this hard work, you change your lifestyle, you overcome the metabolic hurdles of obesity, you celebrate the lower blood pressure and the health milestones.
You're right.
And your reward is chronic chafing and mechanical pain in your most intimate areas.
It's incredibly frustrating for patients.
So since we know the body cannot magically generate new thick collagen fibers on its own, and it can't spontaneously refill those specific fat pads, what are the options? How do patients actually find relief?
Well, clinical interventions are essentially divided into two surgical philosophies to address SFS failure. You either remove the excess or you attempt to restore the volume.
Okay, let's walk through removing the excess first. The literature calls this a labia majoroplasty. I want to be very clear about this because it's so easy to confuse with the term most people have already heard, which is labiaplasty. How do these differ?
A standard labiaplasty is a procedure that typically involves trimming or reducing the size of the inner lips, the labia minora.
Okay.
But a labia majoroplasty specifically targets the outer lips. The surgeon is addressing the SFS failure by physically cutting away the redundant, sagging connective tissue and the excess wrinkled skin of the deflated labia majora.
So they're essentially tailoring the skin tight again, like taking in a dress that's too big.
That's a perfect way to picture it. They tailor the tissue to create a tighter, smoother, more anatomically appropriate contour.
And what about that sagging pouch above the pubic bone?
Right. If the patient is dealing with that, the surgeon will often combine this with a monsplasty. That means physically lifting and removing the excess skin of the mons pubis, sometimes using liposuction to contour whatever small amount of fat remains.
But then we have the second philosophy, which is restoring the volume. This is for patients where the skin isn't necessarily hanging in massive folds, but the area is just severely deflated. The cushion is gone.
Right. In cases of pure deflation, surgeons will attempt to rebuild that protective shock absorber. And the gold standard for this is a technique called fat transfer.
Okay, we have to pause and appreciate the absolute irony of this.
It is quite ironic.
A person spends years fighting fat. They undergo restrictive dieting, they inject GLP-1s, maybe they even undergo major gastrointestinal bypass surgery.
All with this singular defining goal of eliminating adipose tissue from their body.
Right. And at the end of that massive journey, they are paying a surgeon to harvest fat from one area of their body just to inject it back into their labia majora so they can comfortably ride a bicycle.
It completely highlights a major disconnect in how we view body fat. We become so hyper-focused on total fat eradication that we forget adipose tissue serves vital, highly specific architectural purposes.
Fat is not just an evil storage unit. It is engineered cushioning. But wait, mechanically, how does a fat transfer actually work if the scaffolding, the SFS honeycomb we talked about, is completely busted? If the septa are stretched out and broken, doesn't the injected fat just slide around or get absorbed?
That is the technical challenge for the surgeon, for sure. They use specialized cannulas to harvest fat, usually from the inner thighs or abdomen. They purify it, and then they use microdroplet injection techniques.
So they aren't just squirting a huge glob of fat into an empty sack of skin.
No, no. They are carefully threading tiny amounts of fat into whatever structural tissue remains, trying to reinflate those collapsed pockets evenly.
Okay, that makes sense.
The body will naturally reabsorb some of that fat over time, but a portion of it will establish a blood supply and survive, restoring that crucial padding.
And for patients who might not have enough donor fat or who just, don't want a surgical fat transfer?
Clinicians can use injectable hyaluronic acid fillers. These are very similar to the dermal fillers used in facial rejuvenation to plump lips or cheeks, just used in much larger volumes to restore the structural contour of the labia majora.
Okay, so everything we've talked about so far involves needles or scalpels.
Oh.
Are there any non-surgical interventions for people dealing with mild SFS failure who absolutely don't want surgery?
Yes, the field of non-surgical energy devices is growing rapidly. Clinicians are increasingly using tools like fractional CO2 lasers or radiofrequency devices on the external labial tissues.
But how does shining a laser on the skin fix a broken 3D web of collagen underneath? Explain the mechanism there.
It comes down to controlled thermal damage. A CO2 laser applies highly precise heat columns into the dermal layer of the skin. This heat creates microscopic injuries.
And the body reacts to that.
Exactly. When the body detects those micro-injuries, it triggers a massive wound healing response. The body sends in fibroblasts, which you can think of as the construction workers of the cellular world.
And those fibroblasts start churning out new materials.
They are forced to produce brand new, thick, highly organized collagen fibers and new elastin. Over the course of several months, this process gradually tightens the tissue and improves the thickness and elasticity of the skin.
All without making a single surgical incision.
Right. It won't fix a massive overhang of loose skin, but for mild deflation and laxity, it can rebuild some of that lost support.
It is wild how adaptable medical science has to be to keep up with the consequences of this weight loss revolution. We are literally learning how to artificially rebuild the structural scaffolding that rapid weight loss dismantles.
It really is fascinating.
Let's pull all these threads together. What we've uncovered today is that extreme weight loss is far more complex than just a shrinking waistline.
It is a profound physiological event.
It is. The medications and surgeries force the fat cells to empty their lipids, but the connective tissue septa, that SFS honeycomb, remains permanently stretched.
The microscopic architecture of our collagen is completely altered.
And when that connective web in the labia majora fails to retract, it leads to a literal collapse of the body's natural intimate cushioning. That structural failure isn't just cosmetic,
No, it causes severe functional discomfort, chafing, and pain.
requiring specialized surgical or aesthetic care to physically remove the excess skin or restore the volume we were so desperate to lose.
It is a perfect example of how interconnected our anatomy truly is. A change in systemic metabolism results in a localized mechanical failure.
But there's one more layer to this, and I want to leave everyone with a final thought to mull over. While digging through these sources, there was a recurring concept that fundamentally changes how we should think about body fat. White adipose tissue is not just passive, inert blubber.
No, science increasingly recognizes it as the body's largest endocrine organ.
Adipose tissue is highly biochemically active. It is constantly communicating with the rest of the body.
Right, it regulates hormones and it releases these chemical messengers called adipokines.
You can think of adipokines as tiny text messages that fat cells send to coordinate inflammation, metabolism, and vascular health in the surrounding tissues. So if the fat pads in our intimate areas aren't just structural shock absorbers, but are actually vibrant, active hormonal factories sending local signals, what happens when we abruptly shut that factory down?
That is the true frontier of this research. We have a solid grasp on the mechanical and structural failure, the chafing, the SFS collapse. But the long-term metabolic and endocrine legacy of that local fat loss is a huge unknown.
It makes you wonder. We are solving the immediate structural problems with majoroplasties and lasers, but what are the long-term chemical and hormonal consequences of emptying the labia majora of its endocrine cells?
It's a great question.
How might that affect local tissue health, vaginal health, or even sexual function decades down the line? It definitely makes you look at those before and after weight loss photos a little
It
differently.
really does.
The visible triumph on the scale is only half the story. The hidden structural reality is an entirely different journey. Thank you for joining us on this deep dive. Until next time, keep questioning the things you can't see.